the Nursing and Midwifery Sustainability Network event. We hold these events every month on the last Thursday of the month, so please do join us if you can. My name is Angela Hayes. I'm the Nursing Fellow and Project Lead at the Centre for Sustainable Healthcare. Our speaker today is Dr Heather Baid from the University of Brighton. Heather is a registered nurse and a principal lecturer at the University of Brighton with a keen interest in sustainability, and has actually embedded sustainable healthcare into some of the education programmes. Heather has led on a number of projects on sustainable quality improvement, including the National Intensive Care Environmental Sustainability Recipe Book, and is going to talk to us about that today. So I'll hand over to Heather. There will be time for questions and comments at the end. I think we're trying to keep the meetings quite loose, really, and open, so that people can get as much as they can out of the meetings. We are recording, and next month we hope to hear, or we've arranged to hear from Joanne Wilson, who will talk on social care. So if that's all right, Heather, I will hand over to you and turn my mic off. Thank you.
Can I just check, Angela? This meeting goes to 1:30. Did you have anything that you also need to do at the end, or should we just sort of aim to have me finish by 1:30?
Yeah, that's great. Yeah.
Okay. So I'm sure you told me that in the email trail.
No, it's fine. It's fine.
But sometimes, you're not sure if anybody needs any housekeeping at the end. So I recognize some faces. Would it be okay if we just went around and introduced? I'm just curious if people have got an ICU background. This intensive care sustainability recipe book was designed for ICUs, but there's so much in it that's generic to other places. So I'm just curious if people are working in the intensive care community or other areas, and just to kind of tailor the discussion. And I was saying to Angela, for those that were on just a few minutes early, I've got some slides, but I wondered with this size of group whether I might maybe put the slides in the chat as a handout. Certainly some of the introductory stuff, I suspect none of you need any of that kind of what is sustainable healthcare if you're already in this network, but I'll leave it as a handout if you want to share it with your intensive care units, because it's kind of just an overview of what is sustainable healthcare, and then what are some of the national things, which I'll go through maybe a little bit, give you some context for ICU, and then the kind of more details about the recipe book. So I'm an ICU nurse by background, obviously, and I'm currently working at the University of Brighton. Should I just call out names just to kind of, or we could do the kind of virtual ball throw. If you introduce yourself and where you work, and then throw the ball virtually to somebody else to introduce. Angela.
So I've introduced myself. I'm Angela Hayes. I'm the Nursing Fellow and Project Lead at the Centre for Sustainable Healthcare. I also have a background in ITU, so I'm very interested to hear today's talk. Anna.
Hi, so my name is Anna Landry, and I am another one of the co-leads for this group. So really exciting to hear from you, Heather, today. So I work with children in care and work in a community, so a bit different background.
And who are you going to throw to?
Forgot that. I'll throw it to Mark then.
Hi there. My name's Mark Adam. I'm a clinical matron working at HHFT and specifically in Winchester. So at the moment, I'm working on general medical wards. My background is not ITU, so I'm probably one of the few that are not. I have managed a respiratory high care unit, though, for 10 beds down in Portsmouth. So I have an interest really in sustainability, and I'm just about to start a SusQI project. So
Great.
Yeah, I know.
You can present that at a future meeting, hopefully.
I've started, and I've got the survey results coming in, so I'm just waiting. So I mean, I'm doing mine on the disposable scissors that we're using on the ward, and are they actually really disposable, and why they mix materials, and why
that's just as relevant to ICU. And how many of you have the scissors at home because you can't bear to put them in sharp spin? They're still sterile, let alone like dirty. And every nurse takes them home. Yeah.
And I think it's because the back of the packaging actually says single item.
Yeah.
And I'm just wondering whether people see single item, single use, and then they just throw them in sharp spin. But yeah, as you said, I've probably got quite a few scissors in my top drawer of my bedside cabinet.
Every nurse does.
And so can we look on an alternative?
Yeah.
Why don't we spend a little bit more on something that then goes to our sterile services unit and then returns to the ward. So and that's why I joined this group today.
Yeah, and that certainly emphasised that whole idea of a circular economy in throughout the recipe. But yeah. Do you want to throw the virtual ball to somebody else?
Let's throw the virtual ball to Laura.
Morning, I'm Laura. I'm from Sheffield Teaching Hospitals. I'm in the sustainability team here. I'm not actually clinical, but I'm just intrigued to see what we can replicate in our trust.
Who do you want to pass to?
I'll throw to Rachel.
Hi everyone, I'm Rachel. I'm Head of Sustainability at Sheffield Teaching Hospitals, and here for the same reasons as Laura, where we met with Angela when Sheffield was selected for one of the greener nursing challenges. So yeah, just listening to what you guys are doing. But interestingly, reusable scissors is something that we are talking about in our sustainability hub on Friday, and the team who've decided that I didn't know single-use scissors was a thing. So yes, I have many thoughts on what's single-use and what isn't. So yeah, that's a whole new world for me of single-use scissors. I will pass to Michelle.
Hi everybody, my name's Michelle Ingalls. I'm background as a registered nurse, both A&E and community, but I'm lecturing at the University of Glasgow at the moment. I teach the fourth year students a course on kind of global health, climate change, and sustainable healthcare. So
I've just realised why I recognised your name. So we were just emailing. I'm like, oh, I get it. I'm like, I know you. How do I know you? Now I understand.
Thank you very much for the invite.
So we'll follow up on that other thing outside.
Yes. So I'm just obviously just here to hear about what's going on in kind of sustainable healthcare, what's kind of up and coming, and about the recipe book. So thank you, Heather. And I will pass to David.
Yes, hello everyone. So my name is David. I'm also a ER ICU nurse and working in global health currently. I'm working for Doctor Without Borders as in the sustainability team as well, and I'm looking at how to make our medical practices more sustainable. But the type of project we have is very wide, and the key SusQI project we're working on, the main one is on reduction of gloves, and we use it as a sensibilization communication tool, and that's our way to go in. And I'm here to see what you're doing and what could be implementable in our project. So thank you for sharing.
And we met recently because of the SHARE conference. I don't know if anybody went to the SHARE conference last week. The CSH is a collaborating partner with the University of Brighton and Brighton and Sussex Medical School. We do it every year, and we haven't set the date next year yet, but we'll have another one in about a year's time. And David gave it a brilliant talk, actually, and he had some posters as well. We haven't got the video link set up yet, but once it is ready, I'll share it on the network, Angela, because even if you missed the conference, you can watch the videos back. And and highly recommend David just planting that seed for a future network. Actually, I found that really interesting to hear about Médecins Sans Frontières and organizations working in disaster areas and low middle income countries, and just how much collaborative work and how much learning that we can gain from that. So love to continue that conversation, David. Yeah. And is there anybody left for David to throw the ball to? Elizabeth? I can't remember. I've lost the plot now. Oh yes, yeah. We're just introducing ourselves and where you work.
Yeah, I'm having problems with Teams, so I think I just lost connection for a short time. So my name's Liz. I work at Manchester Foundation Trust. I'm a midwife and a nurse. I used to be an intensive care nurse, so I've got personal interest in this as well.
Once an ICU nurse, always an ICU nurse, right?
Yeah, exactly.
Never leaves you.
I do a hybrid role where I'm a sustainability officer as well, 3 days a week, and I work clinically as a midwife for the other part of my week. I know Angela, we both are from Manchester, and just really keen to engage teams to try and be able to replicate some of this work, understanding all the stresses that other people have in different areas, and trying to make it easy for teams to make changes. So really curious about this work.
Great. I think that's everybody now. Have I missed anybody? I feel like we've all introduced us. And Angela's just commented to pop your email in the chat if you haven't yet done so, just because it sounds like some really fantastic opportunities for sharing practices. And Elizabeth, I was just marking papers, and somebody just done it's a postgrad sustainability module we run. It was one of the midwives had just done a proposed SusGrid project on speculum and the is it speculums or specula? Sorry, what's the plural for speculum?
I always say speculums. It probably
Speculums.
is
Speculi. I don't know.
Speculate.
Anyways, disposable versus renewables and costing it out and the sort of short-term costs, long-term costs, and
yeah, it's
yeah,
been there's a project in Cardiff or Swansea that did that already. So
yeah, huge amount of money to be saved. That alone is people aren't interested in the environment. Who cares? You're saving money and carbon at the same time. So that sort of theme is the principle of this, what we're calling a recipe book. So it's not a recipe book of food recipes. Somebody said to me recently they genuinely thought it was like intensive care people, in the schools, sometimes everybody donates a recipe and then you do it as a fundraising thing. They were slightly disappointed that there wasn't cake recipes, I think. So the idea is the intensive care community came together to develop national guidance on how intensive care units can green up, essentially. And rather than call it a checklist or a protocol or a guideline or a pathway or whatever flavor of the month of standard operating procedure of, these kind of guidance documents. One of the doctors, just to recognize where the original idea came from, was Eleanor Dam, who is a registrar and is co-lead of the Intensive Care Society's Environmental Sustainability Working Group. And she said, why don't we call it a recipe book and just be creative in the format? So when you are normally cooking in the kitchen, you've got your ingredients and then you have your methods. And so that's the layout, that's the presentation. There's the 4 principles of the CSH model of sustainable clinical practice. And then we sort of bookended those themes with green team to start off with, because much better to be doing this as a team. And then at the end of it, if you've done projects, research, education, quality improvement, and that sort of dissemination piece. So there's 6 themes and 20, I think it's 20 recipes. I should know, I've been living this project. 20-ish recipes within those themes, which I'll show you an example of in a minute. But just to give you that context, that's where this came from. And we launched it in February. So I have a few slides and I had a little poll thing, but I think what I might do, just because people are from different areas, I might actually skip the poll. And we've sort of done that. It was just about sharing and if, you've done kind of stuff before. I've been doing a lot of these talks because we're in this big year-long national dissemination. And sometimes I'm speaking to big groups only from ICU. So it's been useful doing a little poll to hear from them. Out of curiosity, just while I get my slides up, has anybody heard of the recipe book? Is this brand new, or I'm just... you have done, Elizabeth? And I'm curious, how did you find out about it?
Share from the Share conference.
Oh, did you? Oh, yeah, the Share conference as well. Oh, okay.
Yeah.
Oh, so you saw me do, I did a short presentation there as well. Yeah. How about anybody else? Angela, I know you were, obviously heard about it. And anybody else? David? I'm just looking for watching faces. So there has been some recent, it sounds like mostly through me. I'm just curious if people are finding it in other ways. It's just always tricky to get things out there. Everybody's inundated and, it's another email of something in the email box to look at. So, but the Intensive Care Society, FICM and UK Critical Care Nursing Alliance have been doing this promotion. So everybody cross your fingers, the slides are going to work okay. You never know with Teams, do you? It's just warming up for me. So I can see that now. Can everybody else see that? And I've got my contact details on the slides. I'll pop the whole file in the chat, or you can send it out afterwards, Angela.
Yes.
And I keep meaning to add it as a resource in I think I might have put in the Critical Care SusNet page, but I need to, I've got a bunch of things I want to update on the CSH networks pages and things, and make sure I do that. So the other thing I'll do is, just so I don't forget, I'll pop in the website, because you can download it for free off the Intensive Care Society's website. So I'll pop that link in as well, where the recipe book is there, as long as with a flyer and a sort of tracker document. I have a few slides here, which I'm just going to skip past, because I feel like this is part of everybody's remit already. Sometimes I'm speaking to groups and they've literally never heard about environmental sustainability, etc. And I think everybody's heard about the planetary health crisis. That's why we're all here. And the recipe book didn't focus on social value or ethical procurement, but the remit was really about reducing the carbon footprint. and we had a grant that was specific to that, but we felt it was important to interlink with the social aspects and the NHS supplier roadmap around procuring projects that are prepared and manufactured in a ethical manner, because there's no point in greening up if we're buying products that are made under child labor conditions and, you know, very unethical, which would be illegal in this country, but, you know, with most products being procured from other countries. And so I put some references there, and I don't know, Angela, if we've ever had that at this network meeting, that type of a talk, but just around the sort of interlinks between planetary health and, you know, working conditions. And there's a really good YouTube video, if you haven't yet seen that, called The Human Cost of Healthcare, which it's a pretty poignant video. And I think that image on the slide here comes from that video, just around how all of those scissors and gloves and all the things that we use on a day-to-day basis are manufactured. And obviously these links between planetary health and social health. But I'm going to focus mainly on mitigation, which is what the recipe book focuses on. But more and more there's discussions and sustainability networks on adaptation, isn't there? And certainly the Greener NHS is starting to focus some of their work, or more of the work, around climate resilient healthcare and adapting our infrastructure and resourcing, you know, to be able to be prepared for the heat and the cold and the extreme weather events, and the what do we do when lithium runs out with batteries, and what about electricity, and all of that type of thing. But the remit of this particular recipe book was really about clinical practice and to provide a guidance for clinicians working in ICUs. And I'm sure most, if not all of you, have seen this pie chart from the National NHS England report. David, I guess if you're not working in England, I don't know if you've ever seen the NHS Net Zero report. And they've also embedded it into our Health and Care Act in England, which means greening up is legislated, and it's a statutory requirement for all NHS organisations to have a green plan. And so what the intensive care community was aiming for is, you know, how do we address that blue piece of the puzzle around the clinical aspects of our work? Because as clinicians, we can make such an important reduction in environmental footprint, and yet it's not something that's typically taught to people. So I was never taught this. I don't know if anybody else was. We're now starting to teach that in university undergraduate programs, but that's relatively new. So what do we do about the whole workforce out there that's never been taught it? There's not really a huge amount of research on it, and how do we practice in ICUs in a more sustainable way? So those of you from ICU backgrounds will be familiar with these organizations. There's the British Association of Critical Care Nurses, which is part of the UK Critical Care Nursing Alliance, the Intensive Care Society, and Faculty of Intensive Care Medicine. So they have all got position statements. They've been developing sustainability practices, and they came together to do this very specific project. But just to give some international context, the European Federation of Critical Care Nurses, they've also got a position statement, as do the European Society, the American equivalent, and the Australian, New Zealand. So in the ICU world, there is a fair amount of strategic discussion. But what I find is that that doesn't necessarily filter down to day-to-day work. I don't know, anybody I can't remember when people were introducing themselves, or if you've got connections with your ICUs, or even in just your acute care or community care, wherever you're working, is environmental sustainability something that's becoming more normative, or do you think this is still sort of fringe and the eco warriors doing bits and pieces, but not necessarily everybody? Mark?
It's funny you should use the words eco warriors, because that's what I've said I've become in the last year or so. So
intentionally or unintentionally?
So I recycle at home. My recycle bin has got so much more in it than my normal black bin waste. It's and I'm like, why aren't we doing this in healthcare? Why are we, things like IV antibiotics that come in little boxes, they can be recycled. I have no recycled bin. So the trust had then started about a year ago to sort of invigorate sustainable health and the green project here at Hampshire Hospitals. And it was like, yes, at last. When I worked in a previous trust, I used to have 3 sort of trays in my treatment room. So I'd break it down to the plastics and the cardboardy bits, and I'd have separate bins. And I'm like, why aren't I doing this? So, yeah, and I've just been away on a medicines management day, and we had a whole section around sustainability for the organisation, our medicine's sort of operational leaders and matrons, and yeah, it's sort of gone on a bit from there. And plus, we've got a really passionate sustainability deputy lead called Miranda Chubb here at the organisation, and she's just so passionate about it. And
it makes such a difference when you've got that strong leadership, doesn't it?
Yeah, I just don't understand why other people aren't. But what I've noticed, I think, is some of our international nurses that we've recruited don't particularly understand maybe recycling, and because that's not part of what they do, where they come from.
Yeah.
Which sounds really awful, but it's trying to then go, well, actually, this is what we should be doing. So, you know, my recycle bins now are full of milk bottles and 40-cent bottles and bits of cardboard and paper that was used to scrap paper or thrown away is now all recycled. So it's getting there. So and I think we're not, maybe nurses aren't as passionate about it in amongst everything else that they've got to do in a day-to-day job on the wards.
Even if you are, everybody's just tired and burnt out, and you know, who's got a coffee break, let alone trying to think about being innovative and doing something differently, right? And it's a difficult time to do something new and different.
It is, but I think if you can bring that passion across, which you obviously are, and I can tell that, you know, from the beginning of this, is installing that passion in amongst everybody, and why it's important. Not just about now and just doing a bit of recycling, but about the impact that it has on our climate and long term.
Yeah, because recycling is important and it's useful and it's something tangible that people can see and it gets conversation going. But in terms of which is why I pulled up this slide, I skipped a few slides there, and I'm sure many of you will be familiar with this model from the Centers for Mental Healthcare hosting the network today. And I think you're really exemplifying this model in is it Mark? I can't see your full name there. I think it's Mark was saying around, you know, more than just recycling and looking at prevention, patient self-care, lean service delivery, and low carbon alternatives. So that was the sort of framing that we used for the recipe book. You know, when we started as a team thinking, you know, where do we start? Do we start with recycling? Because that's something people often think of, but actually it's broader than that, and using that bigger picture. So another thing I think, in terms of when we're talking about scissors and other aspects today around, you know, this idea of a circular economy and trying to keep as much resource in the system and to prevent throwing things out as much as possible. Do you know, Angela, I'm glad you posted that. I'm assuming that's from the ICN. Is that the ICN document that just came out about the, it's an ICN webpage, but they just had that big conference in, I want to say Sweden or Finland or somewhere in Scandinavia. And climate change apparently was featured on that. I haven't read it all yet, but several people have sent it to me. I think that might be, oh no, maybe, no, you've put the RCN, I'm mixing up publications. That's the RCN position statement. And then there's some Royal College of Midwives, Green Maternity Challenge. There's also the Born Green generation. Do you want to pop that in the chat, Angela? I'm having a hard time talking and looking at slides and going to the internet based. So Born Green initiative is from Healthcare Without Harm, isn't it? And I think that's still ongoing. The document I'm mentioning, it just came out like several days ago from that big, the International Council of Nurses. And I think it's about defining nursing, and it's not just about sustainability at all, but they've embedded planetary health into such a strategic document. So it really puts nursing at the forefront of or sustainability in the agenda, the forefront of nursing and nursing practice. So for this project, we started off with initially doing focus groups, talking to staff, and we also spoke to some patients, and luckily we had a grant. So the grant paid for a research fellow to be working on this for 9 months. And these are pictures from the research fellow's observations of typical procedures. And even if you don't work in ICU, whether you work in community or theaters or wherever, you know, we're all using a lot of plastics, aren't we? And this sort of reliance on disposable products. Plus often these packages or procedural packs where we open it up, we don't even use half the stuff, or like the scissors are in there, we don't even need them, but it comes with the pack. So we did a lot of scoping around what we can do differently. We did waste evaluations. So these are pictures of 24 hours worth of waste. The highest amount was 32 kilograms for 24 hours from one patient. And it averaged about 10 kilograms for a level 3 patient. So those who work in ICU, level 3 being intensive care patients, and high dependency patients average about 5 kilograms per patient, which sounds relatively small, but there's a lot of patients there. And we scaled it up. We're waiting for a video to come back. We've still not got the video back from the video animation people, but we've given them the data to create a visualization of, what's a typical patient, and then per bit day, and then the a typical ICU, and then kind of across the country, and in a year, how much waste does that look like visually in the way they, and the Carbon Footprint Association, the way they do kind of video animation, which, looking at the draft of it, was quite powerful. So we're always going to create waste. People get sick, they need ICU, but how could we do that in a more sustainable manner? Just to acknowledge, Pat Coelho was the research fellow, who I'm sure would have joined us today. I know she's come to this network meetings, but she's had a baby and off being mom and on maternity leave. So she's currently not at work at the moment. And I think another big aspect that I personally wanted to really look at in this project is waste segregation, and just, we're going to create waste, but at least we could put it in the right bin. If we've got the bins available, that's not always possible, but certainly in an ICU, as a nursing perspective, the easiest place to put stuff is the sharps bin, because we've got one right at the bed space, and typically we do one-to-one nursing if we're lucky. At least in this country, it should be one-to-one nursing if it's a level 3 patient. Obviously with staffing, sometimes we can't always meet that staffing standard. But, to walk across, even if it's a little bit of effort, and just, simple things around only putting sharps in the sharps bin, not putting gloves, not putting packaging, not putting pens, thumb pens, etc. So just to acknowledge, this was a national collaborative project. It wasn't just the University of Brighton. The reason why the university was involved is because that's where I'm employed. So I was asked to lead the project on behalf of the 3 ICU organisations, and it ended up being a partner project, and it was funded by an SBRI Healthcare grant. And just to say that SBRI Healthcare do seem to be doing, I think it's an annual run of innovation grants. David, I think it might need to be NHS England, or like within, I don't know if they would fund something that's international for this particular grant. It's not a research grant, it's an innovation grant, and they have particular calls and different themes, and they're connected with the Health Innovation Network. So if you haven't yet checked out your local regional Health Innovation Network, they do have quite a lot of support for, if you've got an idea of, some kind of innovation of how to be greener, or even something else, something that's innovative in healthcare, but don't know how to go through that process of like, well, how do you develop it? How do you research it? How do you get stakeholder feedback on it? How do you launch it? What are the intellectual property considerations? All of that kind of stuff. I'd really recommend checking out those kinds of organizations. So this particular grant was funded through SBRI Healthcare, but also it was funded with the Greener NHS and in collaboration with the Greener NHS. So as I said, we did focus groups and service user interviews, finding out from people, what do they want in this recipe book? What do they think would be helpful? We worked with Angela's colleagues, Inga and Rosie, and your carbon footprinting team. So the Centre for Sustainable Healthcare was a partner organization as well. And Rosie and Pat, the research fellow, did carbon footprinting of a number of procedures. We haven't published this data yet, but I do have slides here that we did on the launch that I'm able to share. So for those that like to know a little bit more about, well, what kind of carbon footprinting, it was a bit of a combination. Where we found published articles and published LCAs, we used that data and try to do as much cradle to grave process based as possible, but obviously that's limited for some items and procedures. And so procurement based carbon footprinting, and these were the procedures that they carbon footprinted: tracheostomy, central line insertion, IV drug administration, enteral feeding, gastric residual volume monitoring, and mouth care. And the rationale for those particular ones was they were sort of common things that we do a lot in ICUs, and based on what we were hearing from the focus group, so what was sort of feasible for the research fellow to be easily observing while she was monitoring, what did people actually use, not what they say they use or what's in the protocol, but it's interesting when you do actual, almost ethnographic observations and practice of, what really happens, and having photo evidence. And then once you've used supplies, what happens to the waste management and where does that go? So we are publishing these results, and we're going to do a specific presentation on this once we've got a little bit more of that work stream move forward. But this is what the recipe book itself looks like, and the content was the accumulation of the advice from that carbon footprinting exercise, the service user and staff focus groups, as well as what we could find in the literature. It's not a lot of evidence-based practice in this area for ICUs, but where possible, the idea was it would be an evidence-based guidance. And as I said, if you haven't yet found it, I put the link earlier on. You can just download it from the Intensive Care Society website. Even though it was a collaborative project, we felt it was better to have one landing page. So the Intensive Care Society came up with the original idea. And so we're using the ICS website as the sort of place where, you know, future versions will come, and that all the other organizations or anybody else can just cross-reference to. Can you see the font there? I don't know on the slides. I'm doing this on my laptop. Maybe that font's a bit small, but you can see the 20-ish recipes. What we were really commissioned to do was the lean service delivery, you know, reducing that waste, low carbon alternatives. But we felt it was so important to talk about prevention and health promotion that for a lot of ICU clinicians, you feel really disengaged from. You know, health promotion, whoever was working in the community, all that stuff you're doing in community care to prevent having to go to hospital and then getting septic or, I don't know, needing surgery or whatever reason you come to ICU, you know, that's going to be far more sustainable to not need ICU in the first place. Or even if you get to a hospital, you know, critical care outreach and just all those preventative strategies to prevent inappropriate ICU admissions, good end-of-life care, good communication about if people want to come to ICU. So we do have some recipes, if you like, around that, because we felt that that was really important. But also recognizing that that work isn't necessarily what clinicians in ICU are directly involved in, but obviously working with multidisciplinary partners. And this is an example of the team recipe. So each recipe has a little bit of an introduction. It was a national document, so where possible, we've linked in hyperlinks to documents from England, Wales, Scotland, and Northern Ireland, but not all recipes had links for us and things. And sometimes we used international links where needed. Tried to put as many pictures and diagrams, make it really digestible, no pun intended on the food theme, and, you know, to make it more of a kind of easy to use thing rather than something that's really academic and text heavy. And, you know, so it's basically bullet points and starting with the ingredients. So ingredients being often resources or references or, you know, top tips on what are the things to think about that you need in order to do that recipe. And then the methods will be sort of actions. And then we've done a case study for each recipe, just so there's an example of that recipe applied. So that's a picture of the teamwork one. This is the medicines one, because obviously sustainable practices in relation to medicines. And when you look at audits in ICUs, often a lot of polypharmacy and maybe a lot of those medications were needed at some point. And if anybody's ever worked in an ICU, and I've worked in ICUs in Canada where I'm from and here, it's the same, that I think the culture of ICU, particularly the way I was taught, I did my ICU course in the millennial year. And I remember that because we were all worried about that Y2K thing. Do you remember the computer thing? We all thought the computers were going to go off. We were all wondering what's going to happen on New Year's Eve and the ventilators. That was when I was really early in ICU. It was my initial time. So that's very much dating myself. I'm looking at the date 25 years ago. But at that time, we were taught to do lots of stuff. The education on the course I went on is do as much as possible, lots of blood tests, chest x-rays every day, give as much sedation as possible, because I remember my mentor saying, you know, if you were an ICU patient, would you want to remember this experience? So give them midazolam and knock them out, and that's the ethical thing to do. If the ventilator alarms, you give the patient paralysis because that stops the beeps. That's essentially how I was taught. We didn't really get people up out of bed. They were too sedated, if not paralyzed. They all had PA catheters, those who know what I'm talking about, you know, basically a lot of intervention. And I think the culture in ICUs traditionally has been do lots of stuff. Hasn't really been a less is more perspective. And what we now know from not necessarily sustainability research, but just ICU research, if you think about, for those with ICU backgrounds, all the really, you know, game-changing randomized control trials, often it's around doing less, not more. you know, if I think of some recent examples with fluid stewardship, you know, we're probably still giving too much fluid. If we don't give enough, then that's going to be poor quality care. But if we're giving too much, it's also bad for patients and giving them pulmonary edema. And from a sustainability point of view, we're potentially over resuscitating with fluids, over ventilating, over sedating. It's got a financial cost, it's got an environmental cost. And I think medicines is a really good example of that kind of Goldilocks principles of, yes, we need to use them, but not too much and not too little, and the right amount at the right dose. And having the intention to stop. We're really good at starting things in ICU. We're not good at stopping them. So once somebody's on a medication, has anybody thought, even something like paracetamol, which a lot of paracetamol is not needed in the first place, but that's a whole other debate on whether we treat fevers or not. But even if we are, it's for pain management. Maybe they needed it last week. It's a PRN order and everybody's giving it every 6 hours just because, not because there's any intention on whether the patient actually needs it or not. So there's been some really interesting publications I've seen recently around these types of pharmacy projects looking at, you know, what's prescribed in the ICU as well as what's prescribed when they leave. Was this one on the omeprazole? I can't quite see so typing's too small for me here, but you know, just because somebody needed a medication in ICU doesn't necessarily mean they need it on the ward, but nobody's thought to shut that off. They've literally just transferred medications across. I don't know, just to bring some discussion, is that resonating with people who've had exposure to ICUs or maybe even on medical wards or in the community? Are these similar themes to potential for things that are better for patients, but also better for the planet by less is more?
I would definitely agree with you,
Oh,
Heather.
Angela, yeah.
I'd put in the chat there that when I was an ITU nurse, you needed to have your blood gases done every 2 hours on your ventilated patient. And if you didn't have that, you came across as a lazy nurse that wasn't doing your job properly. Whereas now we should be encouraging do them when it's indicated, when it's when there's clinical reasons for it, not.
And I think, sorry, Mark, just before we get to you, I mean, now most places are electronic charting, but in the days of the paper charts, you know, that thing about what I call ICU-itis, the kind of ICU nursing obsession about everything being ever so tidy and ever so lined up and color coded, and the rulers are out for the blood pressures, and you know, your chart has to look pretty. So if you didn't do an ABG regularly, it mucks up the synchronicity of your chart. Nothing to do with the patient, of course, right? But that's so ingrained into the culture. Or we must wash our patients at 6 in the morning because that's what we do, or we must do this every 2 hours because that's what we do. Not that's the way we were taught. Not what does the patient actually need?
Yeah.
Mark.
It's really interesting you're talking about the medications. On management day that we talked about sustainability because there was consultants there, etc., etc. It's like, why are we ordering so many blood tests on our patients? Why, if they're medically fit and they're just waiting for care, why are we doing a repeat set of bloods on them? They're fit. If they were fit and they didn't have care, they'd be at home. Why are we, and it's exactly the same principle on acute medical wards. It's why are we doing that? Why do they need a CT? Can't you do it on the back of the X-ray? What, do they really need a CT? What's, my 85-year-old lady that her management here, we just need to treat what we see now.
Yeah.
We're not going to fix everything. She's 85. It's not going to change. We need to change her health status now and discharge from hospital rather than, what is it that we're doing for our patients that, and it's not great. The more you fiddle with stuff, the more it stinks. So we need to do what's right for the patient, and doing repetitive blood tests, it's a procedure that we don't need to do every day.
There's also iatrogenic anemia. So there's an investigations recipe, and stewardship around ABGs is one of the examples, and there's a really good Australian article that's one of the resources linked in, and it's got this sort of landscape decision tree around, do you really need to do the ABG? And of all the things we do in ICU, I think that's one simple thing we could do is just clean up ABG practices. My day-to-day job is teaching the intensive care nursing course, and when we do the ABG session, I always the week before ask students to bring in an example of one patient and how many ABGs were done in a 24-hour period. And some of them, it's astounding. It's more than 24, like it's more than 2 hourly. You think, however sick they are and whatever you're doing on the ventilator, like you've got to allow time for that to settle in. And what do you, how many of those results is anybody even looking at, right, at that kind of level? But Angela.
It was on the back of what you were saying, Mark, really, about what's absolutely necessary for that patient or what's in the patient's best interest. And the other thing is whether or not an intensive care stay or an intensive care admission is the right thing for that patient as well.
Yeah.
Very often decisions are made to pull out of treatment once they've been in intensive care and they've had all of that stuff in, but it's whether or not that's the right.
It's exactly what you're saying. Why did they go to intensive care in the first place if they are that sick that they're not likely to recover, and you've ventilated the patient, all the associated costs and trauma for the patient, you know, and I've got a big thing about my respect forms for some of our patients. It's like, you know, would you really, what they don't realise is when a doctor leaves the ward at whatever time during the day, it's the nurses that are left to make those decisions. If, you know, somebody has cardiac arrest, you know, they're an 86-year-old with multiple comorbidities that I wouldn't be jumping on their chest, but you have to go through the process because there is no respect form in place.
Yeah.
So
in fact, respect forms is one of the resources in the earlier ones and around that whole debate, because of course we also have to maintain quality care and individual choices, and oftentimes if it's because of a lack of that due to busyness and rather than an intention, and
so that's why I said I think if we can get our respect forms right, then we negate a lot of the stuff that we. It's not saying that we're not doing interventions for our patients. It's just doing the right interventions for our patients at the right time.
All sustainability is the right thing at the right time, and being satisfied that you've reached whatever your goal is, whether it's ICU or community or wherever you are, and whether that's at a clinical level or a kind of department level, but you know, you have some kind of goal and you're sufficing with the resources that you have, financially, environmentally, and social. That's all it is, isn't it? That's, oh gosh, I'm feeling my PhD coming out. If anybody's ever seen my PhD stuff, I basically spent 6 years and wrote 80,000 words about that, but that was it. That's all sustainability is sufficing with the resources we have, not taking away from resources from the future, but still maintaining the goal-oriented care. But Anna, I saw Anna was there. Do you want to say hello, Anna, and make a comment about NICU?
Hi.
Hi, nice to see you.
Nice to see you. Sorry, I was tad late.
That's all right. Do you want to introduce yourself for those who don't know you? Obviously, we've got long-standing history of all of these kind of discussions, don't we? Greening up ICUs.
We do, yeah. So hi, lovely meeting you all. I'm Anna. I work for CSH. I do their new program, the BirdUp program, with education for nurses. So there's going to be 3 new courses coming out in the end of this year. Keep your eyes peeled for that. They're all free, so nobody needs to pay for anything. And just the comment I made. I'm from a pediatric nursing background, so I worked in NICU, and I always find it very interesting to hear from the adult ICU because it feels like so foreign to me to do, for example, what Angela talked about, blood gases every 2 hours, just because in working with preemies, it's always so imperative to not do anything. To as little as possible. Do not stress them because it will immediately have a negative response. So maybe there's something to learn there.
I've done a session with neonatal ICU nurses, and I suggested using tap water for something, and they were just like, no, you know. And maybe there are some things. I think it was GI aspirates, and you know, flushing down. Maybe there's some things that it's okay to do with adults, but we still need some sterility or a difference with neonatal because you know if they're premature and immune systems aren't developed. So I've left the
prevention control is obviously a lot.
Which is the recipe I'm showing right now. So obviously IPC it's kind of a thread throughout, but it got its, you know, such a big topic, isn't it? It's got its own recipe. And this is one where we did have national documents for the 4 nations and lots of gloves off projects going on in different areas. So we used an example of actually one of the local ICUs. Brighton ICU was one of the clinical partners because we had Brighton, Worthing and Tunbridge Wells as ICUs signed up to participate in the project as well. Because we have to be maintaining sterility, but sometimes we don't. Like, you know, the concept of clean versus sterile. And I think this is a cultural thing, having worked in different countries and lots of different places, but the whole apron thing, that's very much a UK phenomenon from my personal experience anyways, having never seen one before I moved here. but also things like sterile water. And I've worked in several ICUs locally where, as a nurse, you crack open a bottle of sterile water. It's what you use for brushing teeth. It's what you use for flushing the NG. And my experience from Canada is use clean water. I'm not saying use dirty water, but it doesn't necessarily need to be sterile. And I think that cultural thing is the end of your 12-hour shift. And so you've cracked open the sterile water and then you throw it out because you wouldn't possibly leave a untidy bed space for the next nurse. And so you get a new sterile water because it's shift change. But it was, 30 seconds before shift change, you would have used it. So that kind of mentality, I think we're sort of in this sort of ritual of practices that aren't really logically thought through, but also are very much not evidence-based and are just financially really expensive. If we forget the carbon footprint, we can't afford it, let alone the environmental impact of all of that. But Mark, you've got your hand up again.
No, sorry. It's just interesting
Yeah.
you were saying about gloves off in ITUs, because it really is starting to irritate me about how culturally ingrained it's become about wearing gloves to it's like physiotherapists that wear gloves to mobilize a patient. Then they're not in a dirty cubicle, they're not isolated because they have an infection. You are walking somebody. We've forgotten the therapeutic benefit of touch. And so after my scissors project, I'm going to start on the gloves one, because
and there's
it's
lots of examples of gloves. The other thing is the National Infection Prevention Society promotes sustainable use of gloves. They've got a whole working stream. Actually, the critical care SusNet, we had one of these types of sessions and we recorded it, and it's on that video is on the link here. So if you want a nice video of it's Graham Pike, some of you might know him, Jenny Wilson, who's leading nurse researcher in infection prevention, and Sam Clark, who's an ICU consultant who led a lot of the early work around gloves off, or some people call them gloves awareness, trying to be more enticing on the language. And the Intensive Care Society, before the recipe book a couple of years ago, did a whole national piece around that. And I've put the link in the chat. They've got an audit tool. They've got a QI template. Like, it's all ready to go if you want to do gloves off. And I think it says gloves off in ICU, but actually the principles are the same anywhere. So even if you're not from ICU, you might find those resources helpful. And they've got really colorful posters that you can put up in the like this PDF file you can download around when is it appropriate to wear gloves and when is it not, for exactly the kinds of things you're saying there, Mark.
Well, we're not even allowed to print off in color, so hey, there you go.
Oh yeah, well, that's true, and it is, I guess, the printed thing. But
honestly.
So Rachel, yes, I know several trusts have done really successful. So after this, Rachel, I'll email you and put some links, because I think precedents can be really important, because especially what a lot of people now call yellow washing, blaming infection prevention policy for something like, oh no, I have to wear the gloves because the infection prevention policy says so, when actually the policy doesn't say so. Neither does the National Infection Prevention Study, neither does the Green Initiative. Like, it's the opposite. So I think getting over some of those myths, what can be really helpful is having case studies and case examples and saying, well, other places have cracked it. The first hospital to do all of this was, gosh, the Great Ormond Street, wasn't it? Going back to pediatrics. And they didn't start it as a sustainability piece. It started with the infection prevention team and the nurse practice of development leads, wasn't it? I've heard those that know about that project. That's my understanding. And I often use that in my teaching as an example of nurse-led widespread change. And it came from the nurses identifying, here's a need to do something relatively simple. I saw them present on that several times when they first launched that project many years ago. And what I remember them saying is phrases like empowering nurses to make their own decisions. Like, is you're a professional. Nobody's saying never wear gloves. Of course, we're going to wear gloves, but you decide. You decide as a professional when it's appropriate and when not. And that sort of encouragement of taking intention in clinical decision making. And that could apply to ABGs or whether you give paracetamol or not, or anything, right? It's that whole kind of like, do I need to do this or not? Rather than just doing things out of habit, out of protocols, because everybody else is doing it, because that's been so ingrained, you'd never really thought about it. Another thing, actually, I meant to say on medicines that we're really bad at in ICU is not giving things IV. We love to give things IV. Why? I don't know, because we work in ICU. Many times the gut's working perfectly fine. Paracetamol is a classic example, but we don't put it in the NG tube just because we like to put it in the IV. And I've had students say to me quite recently, actually, I did a whole session on all the evidence base on stuff and the cost of it and how actually the research shows it doesn't make any difference. It's just as effective either way, as long as the gut's working, etc. But then the response was almost an emotive response. Oh, but it goes straight in the bloodstream and it's just better, isn't it? And I'm like, I've just done a whole like teaching session on the evidence of that. And I think it's just hard to change that culture and that kind of, I don't know, maybe that ICU thing again, that, the whole job of an ICU is to really deep dive and focus in on one patient, and, getting out of some of those kind of habits, I think, can be quite hard, but certainly lots of money to be saved. First of all, question, do you need to give the paracetamol or not? Because a lot of times we don't. I've got a master's student doing that as an audit right now. A lot of the paracetamol, there's no rationale for it at all. And if we are giving it, very rarely does it actually have to be IV. And at least we could give it in a way that's cheaper and doesn't have such a high carbon footprint. I'm just reading through some of the comments around, oh yeah, the World Health Organization. They always do a big annual thing. And the local Brighton Sussex Medical School, they came up with a really nice little animated video for the last World Hand Hygiene Day. I'll dig it out and share it on the network afterwards. And just catching up, I might not be able to get through all of these. Maybe I'll have a look at them afterwards. Just noticing the time. Something to get to 23 past. So lots on lean service delivery, and obviously SusQIs featured in the recipe. And one thing that was interesting, having a service user on the advisory group. So this service user was a former ICU patient. I mean, you can't really recruit people while they're in ICU. It's not exactly appropriate or even feasible to have somebody in an ICU also be on a national project, but had been in ICU. And he brought up questions that we just hadn't thought of, and he heard us talking about this whole thing around gloves, and he said he's so into eco ways of living, which is why he joined the project, and it was very much about promoting planetary health, but he was really concerned about nurses not wearing gloves. He said he'd never seen nurses not wearing gloves, and it was a real eye-opener to, if we're doing all of these greening up things, we know we're making improvements, we know it's better for infection prevention because people wash their hands more and we're saving money, etc. But nobody's talking to the patients about it or families. There's a real disconnect between patient public involvement and environmental sustainability. There's hardly any literature on this. So I'm involved in some local projects around that. We're doing some things around that at the moment. But it was really fantastic having a PPI representative in the advisory group. So he helped us to kind of, I don't know, just have a different way of looking at things, as well as the communication of it. How do we communicate things in a way where it doesn't look like greenwashing, it's authentic, but also one of the themes in the focus groups where people were saying they're very interested in planetary health, but when somebody's critically ill, it's probably not in their mind. And maybe they'd be really resentful to be asked about it, or, if either you are very, very sick, or you might not even be awake, or your family members visiting, it may very well be that that's not the appropriate time to be exploring things with service users. But one of the things Jason said is that families also spend a lot of time in waiting rooms in ICUs, and why not put a flyer up on something about this and where they can find out more information if they're wondering about plastic use. And he said he used to feel so guilty about all the dressings being done. He'd had bilateral amputations, and one of the examples he gave was scissors. He'd see people use scissors, use them once, and he said they didn't even seem dirty. And he asked the doctor about that, who was debriding his foot one day. He was saying, so it's interesting, the kind of, that patient perspective, but also in a way where if they are sick, they need the care. So we shouldn't be having a conversation in a way that they feel guilty about it at the same time. So this is where this flyer came from. And if you notice the language on it, it's caring for the patients as the first thing. So we're trying to be patient-centered as nurses. That's our top priority. But we also care about the earth and maintaining that quality care. So if you want, the flyer is on the website. You can download it for free or tell your local ICUs. And the QR code then goes to the Intensive Care Society website for further information. And the RCN also has a public-facing poster, as you see here, just to try to encourage that language in a way that's meaningful for patients and the public. So we need to wrap up, but just to signpost a couple more things. We created a tracker tool. So you can download this off the sustainability website from the ICS as well. And it's just an Excel spreadsheet. And if you look at the tabs on the bottom, there's a sort of a list of all the recipes. So you can, as a green team, you can kind of keep track of what have we started, what are we in progress, almost like a traffic light thing. And then each tab is one of the recipes as you go through the Excel spreadsheet. And then all the methods are in that. And we were recognizing that in some hospitals, one method might be really easy, where it might be really hard somewhere else. So it's just a way to kind of keep track. And also, if you're doing things in your trust, how do you report it back to your sustainability teams? Because what I find often, people doing really great stuff. You get little pockets of really exemplary SusQI projects and things, and nobody knows about it because nobody's asked them, and there's no reporting mechanism. So it was sort of an encouragement to have ICUs following the recipes to feed that back to their sustainability teams. The two people that were from sustainability teams, I'm sure you'd agree that, you know, wouldn't it be fantastic to know about stuff happening in the hospital. So if you've got any feedback on the recipe book, we'd love to have it. We'd love to have more case studies. You can use me as a way to send in. And if anybody's using it, or if you're encouraging your ICUs, we'd like to have feedback on how people are using it. We're anticipating a version 2 at some point. We knew it wasn't, you can never get anything perfect the first time around. We were restricted by some professional and legalities, you know, some things we would have liked to press the boundaries on. For example, how long you use IV tubing. There's not that much research on it, but the research that's out there says probably you don't need to change it every 3 days. You could probably leave it longer and cause no risk to the patient. But we haven't got enough evidence base to make that kind of statement yet. Or things like not monitoring gastric residual volumes. There's still a feeling like, well, people are still a bit on the fence on that. So we made it as uncontroversial as we could, in the hope of engaging people, and also because it has to represent everybody. But with more and more evidence coming out, hopefully there'll be a version 2 and more sustainable practices all the time. There's also a critical care sustainability network, just like there's a nursing network through the CSH. And final thought in getting students involved. I've mentioned I'm supervising an MSc student at the moment, students on the ICU course. We've had undergraduate nursing students doing fantastic projects. They need to do an assignment on something anyway. So even if they're not necessarily interested in sustainability, sometimes just a gentle nudge. Oh, you want to do a project on this, but have you thought about, you know, thinking about the financial, environmental, and social implications? And before you know it, they've got a SusQI lens on the essay they were writing already, or the pamphlet they were developing, or the project they were doing. So do check out your local university if you're not connected to one. And I guarantee you, if you offer any kind of opportunity for students to do something, they will love it, because there's always a shortage of nurse placements and nurse projects. So I'm going to stop now, but I'll just whiz through. I've got a whole bunch of slides on lots of references and resources, but I'll leave that more as a handout. So a minute to go. Any other thoughts and questions on? Can't seem to stop showing slides.
Yeah.
Oh, there we go. Whistle stop tour of
Anna, did you want to
ICU
say something?
sustainability.
Yeah. Did you have your hand up,
no,
Anna?
I did, but then it was just because I pressed the wrong button, because I simply clapped instead. But yeah, it was really good, Heather. Thank you so much. It was really, really interesting to hear about all the work that you've been doing, and yeah, such a great thing to have, like a one-stop shop to kind of, yeah.
We've had several organizations endorse. If there's any actually, David, I haven't thought about MSF. Maybe I should talk to you about if MSF would be interested in endorsing the recipe book. We need to formalize the process on that. We had some organizations endorse at the point of the launch, but we've had several come to us and say they'd love to endorse it. We've also had organizations asking if they can adapt it and translate it. And the I assumed the people involved would all be like, absolutely, but obviously I have to follow due process because I'm sort of representing the group, which has got 4 organizations in it. So we've had a recent meeting about that. We're going to come up with some guidance and just a kind of Creative Commons or copyright type of thing around if people are adapting and using it for other reasons, fantastic, but just the kind of usual stuff around acknowledgement and things. But so if you're from another area and you think you'd like to adapt them or endorse or use the recipe book in any way, then yeah, please be in touch and we can make that happen. Final thought, we've been teaching it for a while. We've not been very good in the university at assessing sustainability. and I've just converted the recipe book things into a nursing competency. What do we call it? Skills book type thing. So for those from the ICU world, the CC3N is the organization that we have a kind of step 1, 2, 3, and now 4. We're probably not going to have it as a separate skill, but they were interested in embedding into ICU nursing competencies. But I think probably what we'll do is develop some kind of competency of your using the recipe book. How can you be assessed that you're competent in sustainability, if you like? Because I think there's something to be said about that sort of learning process. Under normal learning things, you know, you learn it, but then you're assessed on if you actually know it and use it, etc. So maybe that's a bit of a university lens or CPD accreditation, but it's something that we're working on as well, as around a kind of competency that's built around the skills, or competency skills that's built around the recipe book. Yeah.
That is fantastic, Heather. Really, really wonderful presentation. I'm sure even though it was an ITU based focus, I think there's loads of learning that can be translated and taken into other areas. So I would like to give you a massive thank you, round of applause. I'm sure everybody on the call feels the same.
Well, thanks for the opportunity to speak. I always love this network, and of course, multidisciplinary working is great, and it was very much a multidisciplinary project. But I don't know, it's always nice when you have your nurses around you. Although I'm sorry, that's probably come out wrong because it's being recorded as well. But there's just something I think that I feel like, I guess, in my sustainability world, I don't know if anybody finds the same. There's a lot of doctors doing things, and I rarely find nurses actually. And yet there's a lot of nurses out there, more nurses than there are any other health profession. Yeah. Particularly strategic. If you go high up, I can see people nodding their heads that around, you know, just the power of nursing in terms of volume, and yet there seems to be a lack of a voice. But I think we don't always ask for that voice and things. So, anyways, but yeah, just a thought on nurse advocacy as well. I think this is a real area for nursing leadership that really make a difference. So.
Brilliant. Thank you very much. So next month, it's the 31st of July, and we have, as I say, Joanne Wilson, who will be kind of looking at it from a very different perspective. So she's looking at social care and sustainability in the community. So that will make a nice contrast to the stuff we've heard about today from Heather. So one more time, thank you very much, Heather, for joining us. It's really, really been a wonderful presentation. So delighted to have you join us. Thank you very much.
All right. Bye, everybody. Enjoy the afternoon.
Thank you.